Hi there, and welcome to another episode of Cut to It, the nursing podcast, bringing information we hope that you will utilize in your practice and also maybe give you some articles that you can go and look out for the best evidence practice. And we are really burning to talk to you about something today. I'm Dr. Rosemary Babo. I am a operating room nurse, global education, clinical specialist. Love bringing this information to you. And my co-host.
Hi, Marianne Sanford here, also registered nurse, operating room nurse, worked also in global clinical affairs, global medical affairs, and happy to be with you today.
So, what we're going to talk about today, surgical fires, rare, preventable, and still happening. So, what are you finding, Marianne, in the literature? What's going on with this?
Well, the literature talks about a lot of it reminds people about how a surgical fire starts, right? So we know there's an ignition source of some sort. It could be a bovie, a laser, fiber optic light sources, etc. We know there's a fuel source of some sort always, and these three things that I'm going to mention, by the way, happen in
Right.
every surgical fire. Yep,
Yeah.
that's right, the triad of fire or whatever they
Yeah.
called it. So the second thing is a fuel source, and what that is prep solutions. That's a big
Mhm.
one. Sponges, drapes, towels, things like that, and anesthesia circuits, which we sometimes forget about. And then the last part of the triangle is an oxidizer. And it doesn't need to be supplemental oxygen, by the way. The literature talks about other sources. It could be ambient air supporting those fuel levels, but it's not always oxygen. So that's important to remember. So
Yeah.
that's the triad of fire and how it actually occurs.
Very cool. And are people just unaware of this? I mean, I have some case studies that I would like to share, but you tell me how you want to talk about it. What are you finding?
Well, one of the things that I found in the literature is that the incidence of surgical fires has increased since there's the alcohol-based preps. So, and really that predates all of the fires predate the use of surgical checklists. So that's been a very important concept and very important mitigator for surgical fires, and that is without question all over the literature.
So do you want let me jump in and I'll give you a little bit of what I found. And these are recent case studies. This one came out of Harvard. There was a 74-year-old male. He had a temporal artery biopsy. The oxygen was just a face mask and it was open delivery. And cautery was used for dissection. And the drapes limited the visibility of his face. So, what happened was the spark, the oxygen, and the enriched environment, the mask ignited, the flames were visible under the drapes, and the patients sustained second-degree facial burns. So, this was actually one of the most preventable versions of a surgical fire, but it also happens to be one of the most common. And it seems like it's a routine, low risk procedure. Everyone in the room was doing something normal. Yet there was a failure by the team to recognize and be aware of oxygen management.
So you talk about that procedure, which is just horrific, right? Horrific for the patient and the fear that must have been in the staff when when they noticed that that was happening. When you have general anesthesia, typically is with an LMA or endotracheal tube or whatever. So the oxygen is being delivered past the face. So when you talk about head and neck surgery, the oxygen is being delivered away from any of those ignition sources and any of those fuel sources because there's a cuff at the bottom. LMA sits on
Mhm.
top and the endotracheal just sits lower down. So that doesn't mean it's perfect, right? Everything could leak around it, and that doesn't happen that often, thank goodness. But that's totally different than a mask that's on the patient because the mask, even like a CPAP mask, the
Mhm.
air, or in this case oxygen, can leak out from underneath. So you still have that oxidizer. The oxygen is right there. And in head and neck surgery, where's the cautery? right there, temporal artery, right? So, and then you just mentioned that was the drapes that that caught on fire. So that's that fuel source. So unfortunately for this patient, all the elements, that triangle we were talking about, were all there for the patient. And a second degree burn, of course, is so serious and very, very painful. So, what an unfortunate event to have happened.
Yeah. Yeah. The next case, you brought up alcohol prep and how it might be hiding in plain sight. So, our current preps are about 70% alcohol. This one was a peripheral vascular surgery. So, the leg, you wouldn't even think anywhere near the oxygen. However, an alcohol based prep solution was used and it was reapplied, general anesthesia with only about 30% oxygen. Well, what happened? We had alcohol vapors that got trapped in the skin folds around the drapes, under the
Oh,
drapes. And
oh,
then the cautery ignited vapors, and the results was a second-degree burn to the leg. So you
wow.
don't really need high oxygen, you just need room air, and the vaporized prep seems to be enough. Skin folds is another thing maybe we should talk about because I don't know how many times people go in and double check that during the procedure. Personally, I have not seen people double checking that in the procedure, going under the drape, seeing if there's, alcohol collecting or prep collecting in skin folds. And anymore, I'm sorry to say, but there are a lot of skin folds on patients. We've
Mhm.
had a lot of instances, that you have to look at that maybe you didn't have to look at 30, 40 years ago. Um, so that, it oxygen isn't always the main culprit. Fuel alone can also drive the fire.
Yeah, yeah, and I would say, and the point you're bringing up about skin folds, we're a more heavy the generation, a more heavy population of patients, and peripheral artery disease. Are they diabetic? They might potentially, from
Yeah.
diabetes, be overweight. But it's challenging for me to understand the skin fold issue because your job, all of you in the OR, is to make sure that that prep is dry. And we all know clinicians that don't want to wait. Come on, let's go. And there has to be an advocate for the patient that says, no, we have to wait for this to be fully dry. Now, of course, prepping the whole leg, putting the glove on the feet or whatever, and then prepping the whole leg, it's going to run down. So it should be an automatic thought that it's going to run down in the regular crease of the thigh, right? The thigh and the abdomen. So that's almost the most critical point, to your point, that they should be looking at that. And it's really everyone, because the surgical team could, maybe they could take a sponge stick and just dab it and make sure it's actually dry. But there should be an emphasis on that because, yeah, how imagine this again, this poor patient, and there's no really oxygen risk there
Yeah.
because it's not under anywhere near the field. But uh, again, you have the prep solutions, you've got sponges and drapes right there. You have all the cautery, right? You have all the elements to start a fire. And in that case, gosh, just so unfortunate.
Well, I worked with a surgeon that always wanted to do his own prep. Didn't matter,
Yeah.
just always did his own prep, so
Okay.
either he and I never asked him, whether he had an incident in the past that made him want to do that or that was just his, thing because of all that we've outlined. You don't go through everything that you've gone through and then have something like this happen. So, I think, hats off to him that he really cared about the patient and making sure that everything was pristine before he even started the surgery.
Right, right. You know,
So,
uh,
yeah,
betadine was used for a very long time, and you still had to let betadine dry for it to be effective,
yeah.
but you didn't worry about the pooling. That just wasn't a thought, right? And so these more effective alcohol-based preps, while they're amazing, of course, now they're coming along with a risk that probably isn't thought about very often when they're used.
Well, I will say that and I don't need to maybe name these people, and I actually haven't followed up, but I know that I was at one of the conferences and there was a vendor that was, they had addressed that situation by having a different color. And you when it
Okay.
dried, you could see, you'd be able to tell if it was still wet. So I really, hats off to them for taking that extra step because people are rushed, and you know what? We wouldn't even have this topic if everybody did what they were supposed to do, and I think this is another one that is a little bit less reported, even though these are very recent, 23, 24, and then 22. These things were reported and they made it out into, the public, um, forum, because I didn't have, a institution pull these for me. These are out there. And like you
Mm,
said, the mod report as well. That's another very
yeah.
good,
Yeah,
opportunity.
let's get into the MAUD report. I don't know
Yeah.
that a lot of people in the OR know what MAUD is. So MAUD is a database that's managed by the FDA, Federal Drug Administration, and anyone can post to it. If you're a patient and you have a complication, you can post to it. Nurses, surgeons, anesthesia, anybody can post to this database. And the database is the manufacturer and user facility device experimental database. That's why they say MAUD. It's just a lot to say. So, one of the clinical studies that I was looking at looked at the data in the MAUD database from 2000 to 2020. So that was 10 years, right? Sorry, 20 years.
Yeah.
And they identified in that 20-year period, again in the MAUD database, 565 surgical fires, which, my goodness, that just sounds awful, right? And that was in a study period of 20 years. So when you think about a 20-year period, it's just awful. It shouldn't happen as much, but it was pretty common. So there was a range of 8 to 53 fires per year, but the median was 25 fires per year. And 25 is too much, right?
Well,
By the
yeah.
way, the MAUD database is US only. It's not multiple countries. Um, Most likely, they come up to be again in the head and neck or the aerodigestive tract. So it can even be endoscopy, which, oh my goodness, like an
Yeah.
endoscopy fire. Wow. Um, they also these head and neck surgeries, when there was a fire, had the highest incidence of life-threatening surgery, and you think about it, it's your airway. I mean, you only have one airway, so, um, in this case, 82% of the fires were caused by an electrical surgical device, so like a Bovie,
Yeah.
which 82%, there's your ignition source. It's not hard to comprehend why that would happen. The root causes, and I'll look at my list here of what was, identified. The prep of the surgical site, that was almost 30%. Device malfunction, which they weren't really explaining so much, that's 26%. Surgical accident, and you notice now a trend here. They're not really clear on what they were, and this may be an artifact of who's actually reporting it.
Yeah.
Uh, Medical judgment, maybe not using maybe not using the device when you have all these other sources of potential fire. Equipment care and handling, patient factors, I don't know, maybe that's an anatomy issue. Communication was 2%, so I thought that was pretty interesting.
Yeah.
Um, there were 5 of the 565, there were 531 incidents of patient harm. Um, 427, that's 75% required an intervention, like you were talking about the burns, the second-degree burns. And 34 of those patients, that's 6%, had life-threatening injuries. So it was certainly an adverse event that was not minor. It was a SAE. We would call it a serious adverse event. 3% of the patients died out of that 560. But interestingly, 87%, 87, that's 15%, had no injury. So very, very interesting data and sad data that we had so many over that 20-year period. But and again, remember the MAUD database is self-reported. It's somebody reporting it. It's not a required report. And that's something else I wanted to mention, that the data there's no universal standard for reporting the fire. It's maybe through the policy of the medical facility, the hospital or surgery center. Uh, there might be some rule there, but no state requires a report of a surgical fire. And so there's universal guidelines don't exist when it comes to surgical fire. Like in the medical device world, you and I both know there's mandatory reporting when
Yeah.
something like that happens. And that also includes the sales rep, right? So that's a totally different thing. And you would think that surgical fires would be mandatory reporting, and actually it is not.
Well, just think about that as we close this episode, that you have a patient, or even if it was you or your loved one, went in for a surgery that seemed, pretty routine, and someone you loved died. And then just think about that. You They died in the OR because of a fire. And if you have any comments or suggestions, let us know. We'd be glad to hear from you. And I don't mean to end on a sober note, but or somber. It's both. I am sober and it is somber. But really think about what's going on when you're in there with the patients. I know it gets busy. I know you run through cases so quickly, it seems, and the days run together, but it really could mean somebody's life. So email us at cuttoitpodcast@gmail.com. Share the videos and any information that you have that you know can help bring us another topic of what you want to hear, and also look at the evidence that we're presenting so you can utilize it in your unit.
Yes. Thanks for joining. Really appreciate you. Hope to see you joining on the next podcast. Take
Bye
care.
bye.